This is the beginning of Module 3. Now, I know that this hasn't really been the best year for having a class with the constant barrage of hurricanes that have come through, and now you guys have a Cat 4 in the Gulf as well, or it's about to be. So we'll deal with that as it comes. However, that being said, we did have a window of opportunity for you guys to catch up, and a lot of you have. All right, most of everybody has gotten Module 1 done. Module 2 is pretty much, it was supposed to be done by tonight. However, I know that because we've kind of been backed up on the testing, I'm not going to be real anal about y'all being on it to the date. Now, that being said, I'd rather it get done before the end of the week if possible. So some of y'all still have some tests to go. Some of you are already done. Congratulations and good job being caught up with the class. We're starting up with Module 3 tonight. So yeah, I don't want you guys to get behind because this module is probably going to be the hardest module in the class. This is medical emergencies. We're going to be going over a lot of information, and it's going to be hard to keep up with this while you're still going back trying to catch up the things that you are already behind on. Some people still haven't taken any tests, so I'll be emailing you guys. If you can't get some progress done by the end of the week, I'm probably going to have to remove you from the class. It's just, we're way too far in. It's going to be almost impossible for you to catch up at this point. We do have other classes coming. If you want to try again for January or July, you're more than welcome to hit those. But anyway, on to tonight's lectures. So yes, we are going to hit shock. We're going to talk about shock more when we get to trauma as well as cardiac emergencies. No, that's no problem. Just figured I'd answer it publicly. Yes, we're not done with shock. We're going to hit shock a few times. We're just going to hit it from different, because that's such a big deal to an EMT. So we're going to talk about shock multiple times throughout the course. And then I don't believe I made y'all have a test on shock without going over it, but if I did, let me know and I'll go back and review that. So tonight we're just going to go over an overview of medical emergencies. Like I said, this is short. We're not getting into the actual medical emergencies. We're just talking about how we're going to go about doing this stuff. Now, if y'all, I'm going to make reference to your assessments. So if you want to pull up your medical assessment, do it. In fact, I tell you what, I'm going to pull up the roster because we're going to have a little review real quick about the assessments actually. Don't everybody sign off on me. All right. Let's start with John. John Rivera, you're pretty much on this, so not a big deal if you get it wrong, but I just want to try to kind of figure out where y'all are at. Okay. Do me a favor. Since we're going into medical emergencies, what mnemonic, and you don't have to tell me what it all means, but what's the acronym mnemonic that we use to figure out the details of somebody's pain? Good. OPQRST. All right. Anybody want to take a crack at telling me what those mean? Now, before we just start rattling off the words, I want you to think about a question that you would ask with that as well. So when you pick one, and you don't have to do them in order, but just pick a letter and then put a question to it. And because that's going to be a lot of typing, you guys can, y'all can actually say this over voice. So what is, all right, so onset, we'll go with that one. Corey, this one will be yours. You can unmute for it. What is your onset? It's probably not the right way to go about it. And it's not wrong. Oh, you don't have a mic. Okay. Type that one. While you're typing it, we'll move on to a different one. Sharon, is your mic working?
Yes.
Okay. All right, Sharon. Tell me what P stands for, and then give me a question that you would ask to figure that one out. While you're thinking about that, we'll go ahead and read what Corey wrote. So onset, what is
How
causing?
would you rate your pain on a scale from 1 to 10? Sorry, my mic wasn't working.
That's all right. Okay, so pain scale is that's actually going to be the severity. That's the S. So what does P stand for in OPQRST?
Provocation.
Provocation. Good. So onset. We'll start with that because that's where Corey at. Onset. What is causing you to have this problem? You have to say what brought it on. All right. So that's a good one. So like, what were you doing, right? And then for P, for your sharing, provocation is, does anything make it worse? And a good example of that is, let's say that we go to somebody's house and they're having severe abdominal pains and it's in the right lower quadrant. Um, that usually screams appendicitis to us. And there's a very specific thing that you can do if you've ever had that. You probably know it, but we call it rebound tenderness, where the pain actually gets a little bit less if you press on it. But the minute you move your hands and that pressure off of that area, it just comes back with a screaming vengeance. Um, so for provocation, a good question would be, first of all, you want to keep them open-ended. So is there anything that makes it better or worse, right? So if they're like, yeah, it's better when I press on it, but the minute I let go, it hurts really, really bad. That can kind of tell you, that leads you down the appendicitis route. There's some other things, and we'll get into the specifics of it when we go through this module because that's what we're going to be learning about. But from an assessment standpoint, I just wanted to go over and make sure you guys are up on the acronyms and what they mean because we're going to really we're going to hit hard in this module. All right, so Q. Um, Michael Allen, you feel like taking Q and what Q stands for? Not tonight. All right, that's no problem. Any volunteers?
Quality.
Quality. All right, and what would be a good question for quality?
How would you describe your pain?
Perfect. Perfect. All right. Yes, because depending on how they describe their pain can kind of lead you down the road of, is this an organ? Is this a muscle? I know we've talked about that before, about the amount of nerve endings that a muscle has versus what an organ has. So if it's a muscle problem, or like a visceral lining or something of that sort, their quality, the pain is going to be very sharp, very pinpointed. They can say it hurts right here, and it's very, very bad. If it's an organ, um, the pain is very diffuse. And I'm not saying that it's dull, like doesn't hurt. It's just, it's kind of spread out. It could be the entire quadrant that it's in, right? So right lower quadrant pain, for appendicitis, when the appendix starts to enlarge, there's fewer nerve endings. So you can't really pinpoint where the pain is. It pretty much is that entire quarter of your abdomen that is just on fire, basically. Um, So asking them questions like for Q, describe the pain, let them tell you. Try not to pigeonhole it, try not to lead them down sharp or dull, but let them put it in their own words, and then you just kind of interpret that yourself as to what they're saying. So R, any volunteers for R, what R stands for? Well, you were ready for that.
Region.
Corey you must have been waiting to hit enter. So it's not region, it's radiation. Because remember, we're talking about the pain, not necessarily where it's at. We're just which would be region. We're looking at where, like, does the pain go anywhere else? So deferred pain. If it's a cardiac problem and their heart's the issue, a lot of times males will tell you that they have pain radiating down their left arm. That's a common deferred pain for male cardiac issues. Women, theirs is a little bit different. A lot of times they'll tell you it hurts down in their stomach. Theirs, for whatever reason, they just have a different type of pain. You're not as likely to hear a woman tell you that her left arm is hurting if she's having a heart attack. Um, let's see, another one. Anybody tell me another organ that tends to kind of hurt around a different part of the body that kind of stretches out? Region radiation. Oh, that is interesting. I wonder why they put that. Because that's region doesn't make any sense compared to, as to what R stands for. So ignore what the book says about region. when we talk about R for OPQRST, it's radiation that we want to focus on. So we're talking about, does it radiate anywhere? Is there any kind of deferred pain? Another example besides the heart would be the kidneys. You talk about deferred pain from kidneys. A lot of times you can feel that in your flank or like around to your back. It'll feel like lower back pain. That's kind of what R is getting at. All right. Then we already talked about S. S is severity. That's your pain scale. And if somebody's having a really bad day, if somebody's having a really bad day, it will always be a 10. It could be, you might be looking at them going like, man, this can't be that bad. But if it's bad enough for them to call 911, usually it's a 10. They'll even just tell you it's a 10 or 12. Yeah, they'll give you some number that doesn't, like, well, you could have just said 10, man. But all right, and then the last one, yeah, I'm sorry that the book said region. I don't know why that's there. It just doesn't fit. I can't see where region would have made sense. But and then the last one is time. So good job. Now give me a question you would ask for time. When did it begin? Okay, which can kind of put some math into you if you ask it that way. I mean, yes, that is absolutely a valid question. You could also,
Or how long has this been going on? Like, how long have you been dealing with this?
there you go. Yeah, so you can make the patient tell you and let them do the math. Say, how long has he been like this? How long has this pain been there? And let them be like, well, I suppose about 3 hours ago, as opposed to saying started at 2 or something of that sort. Um, did this start this morning or a week? Yeah, you can go that route. I wouldn't try to put a time frame to it because then they're going to try to say, yeah, it was this morning. They're going to pick one, and it really might have been like say last night. Um, so keep them open. You're on the right track with what you're asking. Just try not to let it be a closed-ended question like that. Uh, when did the pain start? How long has it been going on? If it's not pain, let's say you're using OPQRST for a stroke patient. That's a very important question because some of the main treatments that they're going to get at the hospital are time dependent. If they've been acting up for like 48 hours, most of your procedures at the hospital they're not even going to bother with it because it's been too long. So that's a really good question to ask. Um, any patient that's got pain, but if you're dealing with a stroke patient, that time question should probably be the first of the OPQRST. You don't necessarily have to do those in order. They're just put in that order so you can remember what the questions are, right? Same thing with sample. You can start with medications and allergies or what they ate or whatever. As long as you get all the questions, that's really all that matters. So you guys start doing these hands-on out loud with us at the boot camp or whatever. If you go to do sample and you go straight to meds or something, that's fine. Just make sure you catch all of the questions. All right, good. So that's OPQRST. The reason I wanted to hit on that tonight is because we're going to be using that a lot in the medical aspect. You can kind of put DCAT BTLS on the back burner for now because we're not going to be dealing with that. That's going to be in the next module, which is trauma. Let's see. Any volunteers to tell me what your scene size up consists of?
Is the scene safe and how many patients you have?
Okay, good. So we have, yep, is your scene safe? How many patients do you have? There's a few other steps. What else we got? We have the MOI. Hazards goes into scene safety. That's good. What else do we need to pay attention to? Any additional resources? Good. So that goes hand in hand with how many patients do I have? Not just the patients though, right? We're also looking at, like John said, you're looking at hazards. Some of your additional resources may be a hazmat team or the fire department or an electrician or something like that. Yep, power lines, anything that kind of plays into your safety. Anybody think of anything else? Y'all look at your assessments and see if there's anything you're missing.
What signs and symptoms are the patients presenting?
Not signs and symptoms. We're not to the patient yet. Which one? The neighbor's attack dog? All right, so y'all are hitting around it. So first of all, you have BSI and Scene Safety, and if you look at your checklist, that's actually that's two different lines. So that's one and number two. BSI, that's your glove. Scene Safety, that's the neighbor's attack dog, the gun sitting on the table, blah blah blah. Then you need to know how many patients do you have, right? Figure out if you need any additional resources. Look for your MOI, or in this module, we're going to look at the NOI, which is the nature of illness. And then you're going to move on from there. You're going to do your LOC, level of consciousness, and then from there, you move into your primary. The reason that we do the LOC prior is because if they don't have a pulse and we have to go into CPR, then we're going to wind up having to go to C first. It becomes CAB, right? That's how we do CPR. But if they have a pulse, if we're not going to be doing CPR, then we can go the regular DBC route. So that's pretty much your scene size up, and I'll hit this again every night. That's usually the hardest part for people, is the scene size up. A, because you're just getting rolling in your assessment. You're trying to get that start, and B, it's just not medical. It's not. All it is painting a scene, and it's not what we focus on. We're also focused on what do we do with our patient. And that's kind of everybody's downfall, is that they'll come into an evaluation, they see the patient all laid up on the ground, be it a real person or a mannequin, and they're covered in blood and they've got all this mucilage set, and they're like, all right, here's what we're going to do. And they get down there with the patient and they completely skip the entire initial assessment, which of course means they fail. So I don't want you guys to do that. I want to get the initial assessment into your heads to where if you don't know anything else, you can recite that in your sleep, with alcohol in you or something, just where you definitely know it. But we're going to move on a little bit. Let's go ahead and actually get into the chapter. So patients who need EMS generally have experienced a medical emergency, a trauma, or both. There are plenty of times where one will cause the other. So not everybody's going to be black and white, always medical or always trauma. Trauma emergencies involve injuries that you can see, because usually they're inflicted on the body from an outside source. Medical emergencies are a little bit more like a Sherlock Holmes novel. You are trying to figure out what's wrong and you can't really see it. It's a little bit more difficult, but it's also a little bit more fun, to me, at least. As I've progressed in the field, I started off, I loved trauma. Trauma was great because I could see it, but ultimately it was because it was easy. You see a broken bone, you fix a broken bone, you move on. Medical, when you're first getting started, typically the only thing you've mastered with medical emergencies is the questions to ask, and it's just extremely boring. It sucks. So, but the more you do it and the more you learn, the more you start to really get better at it. So, like I said, me personally, I prefer medical stuff. I've actually gotten to where I'd rather deal with somebody telling me they have a stomach ache than deal with somebody with a broken bone. It's just, I don't know. It's fun. It's more interesting to me. So a couple different medical emergencies you're going to run into in the field. We have respiratory emergencies. You're going to see these a lot because there's a few things that can cause it. So essentially, this is just any patient that's having trouble breathing or is not getting the right amount of oxygen actually through their lungs and into the blood. So we're looking at, problems with the airway causing a ventilatory issue, or problems with the lungs, or even to some extent, it could be some blood issues that are causing the patient to not be able to get oxygen into their bloodstream properly. We have cardiovascular emergencies. All right, this is pretty much anything to do with the heart or the circulatory system itself. So heart attacks, congestive heart failure, and again, with that example, you can kind of see where sometimes one emergency will screw up another system, because congestive heart failure, you're going to actually treat that more like a respiratory emergency than you are a cardiac emergency, even though the problem technically is the heart. There's not a lot we can do for the heart, especially as basics, but we can be aggressive with treating their respiratory system and save their life, even though it's technically a cardiac issue that they're having. Neurologic issues are involving the brain and the spinal cord. Usually these are strokes when we talk about medical issues. There's others though. You can have fainting, seizures, any of those sort, we're technically going to be neurologic issues. GI conditions, gastrointestinal conditions, so appendicitis, which is a lot more common than it probably should be. I don't know what causes so many people to have appendicitis, but all the time, run appendicitis all the time. Diverticulitis, pancreatitis, and many others. A lot of your itises are going to be in there. Urologic emergencies can involve kidney stones. If you've ever passed one of those, I am sorry. The most common endocrine emergencies that you're going to run into are complications involving diabetes. In fact, when we get to the endocrine chapter, is pretty much all we're going to talk about is diabetes. Hematologic blood emergencies have to do with the blood. So the big thing that we want you to understand is an EMT, and you can learn more when you go to advanced or if you go to paramedic, but we really want you to have a good understanding of sickle cell, just because it's really common. It can be life-threatening, but it's something that people live with. So we want you to understand that. But there's some other issues like hemophilia that we'll talk about. But the big thing is sickle cell, and just understand that, because if somebody is suffering from sickle cell, you're gonna see that, like, a lot of your interventions don't do what you expect them to do. You put somebody on 15 liters non-rebreather, you expect to see their O2 sats jump to 100. But with sickle cell, that may not be the case. Immunologic emergencies, these involve the body's response to foreign substances. Some steroids will cause somebody to have this issue, some actual chronic issues, some worse than others. Some people just have weak immune systems. Allergic reactions, we're going to have a chapter devoted to that one. It's a type of immunologic emergency where it can be anything from just some rashes on your skin to life-threatening, I can't breathe kind of emergencies. It depends on how bad it is. It can extend to its own version of shock, which we call anaphylaxis. I mean, if I ever woke up and found out I was allergic to shellfish, I'd probably just shoot myself. I ain't gonna lie. That's up there with the catheter to me. I'll take a dose of lead before I deal with that. Anyway, toxicologic emergencies. These include poisonings and substance abuse, and this can be accidental or on purpose. They're just all together. Anything that's gonna make the body infected like that, but not from a biological issue. All right, and then gynecologic emergencies. These involve female reproductive organs. So this can be anything just to do with the organs themselves. It can also have a little bit to do with childbirth. It just depends on the issue. Some medical emergencies are caused by psychological or behavioral problems, and we're going to talk about behavioral issues later in the class as well. You guys are actually going to get a class devoted just to Alzheimer's and dementia on top of your regular ones. So we're going to have the chapter that just touches on all the different psychological emergencies that are out there, and you guys are going to get dementia and Alzheimer's, as you're going to be experts on it by the end of the class. All right, let's see. Moving on. All right, so moving on to our patient assessment, and again, now we're going to be talking about the medical assessment. So focus on that if you pull up your actual assessment checklist, that's what we're going to be talking about tonight. Assessment of the medical patient is similar to assessment of the trauma patient, but there's a couple of differences. First of all, the MOI/NOI option. If we're talking about medical, we are talking about illness. So nature of illness, there is not typically an MOI involved in these unless it's one of those combination calls where it was, diabetic emergency while driving down the road, ran into a tree. Your symptoms are going to be different, and your chief complaint can be different, but you're going to focus on those. There's really not a head-to-toe assessment in the medical assessment. It does exist, And depending on what your problem is, what their chief complaint is, you may or may not do one. If they have an altered level of consciousness or they're unconscious, you're definitely going to do it because we don't know. They can't tell us if there's something wrong, right? Um, but we're going to focus our assessment on the nature of the illness, the symptoms, and their chief complaint. We're going to establish a accurate medical history. Now, again, I don't really want you guys to get their entire life story, but try to get as much information as you can that is based on their chief complaint. So if the chief complaint is something about a stomach ache, then focus your history on that. Don't worry about broken ankles or, I don't know, behavioral emergencies or something like that that don't really apply. You can use dispatch information, but keep in mind that they're getting at best secondhand information. Typically, it's not the person who is having the emergency that's calling 911, it's somebody else. So the information they give you may be inaccurate. It's not really their fault usually. Sometimes it is, but most of the time it's just that the person on the phone is giving them inaccurate information. So you can listen to dispatch, obviously, like definitely listen to what they're saying, but take it with a grain of salt because what you see on scene may not match with what was actually told to them. Injuries may distract from the underlying condition, and you'll see that when you do your evals. We may give you an evaluation that has some pretty gnarly distractor injuries in it, like broken bones, and we'll focus on those, but we don't want you to focus on those. We want you to focus on your assessment so that you don't let that nice, pretty picture of a distraction mess with you. Tunnel vision can occur if it's a scene that messes with your head, a buddy of mine, I know I showed some of y'all, but a buddy of mine sent me pictures of his first call of the day. I don't know, it's been about a month or two now, and it looked like a murder scene from a horror movie. There was blood everywhere. There was glass on the floor. In fact, just the blood that was in the pictures looked like enough to make somebody die of blood loss. That was his first call. That's what he opened his shift with, and then it just went downhill from there. So whatever happened to him after that was worse. I don't know. All I know is what he shared from his first call, and he said, "I wish that was the worst, but it got even worse from there." Um, that's why we have the assessments, right? So when you walk in and the shit's hit the fan, you can do as my paramedic instructor used to say, and unfuck yourself, and then um, start with BSI Scene Safety and just go down the list if you have to. Assessments can be difficult with uncooperative or hostile patients. We're going to have fun with this when we give you guys the behavioral emergency scenarios. So don't take it personally. You're welcome to laugh with us if we can't keep a straight face either, but you'll see. Sometimes it's just mayhem and you have an unruly patient or whatever. You just have to find a way to deal with it as best you can. Maintain a professional, calm, non-judgmental demeanor. Don't shout at the patient. Um, Refrain from labeling patients, right? I mean, you see that happen all the time. People are like, if it's an overdose, suddenly they're a drug addict, even if it was accidental. Cops sometimes can be bad about labeling diabetic patients as being drunk. And they've gotten better about that, but that is still an example. Yeah, embrace the suck. A frequent caller may have a different complaint this time. So a good example of that would be even just not even an EMS example, but you know, every time it would lightning somewhere in the county, we had a building that the fire alarm would go off on every single time. So if it clouded up outside and we got that call, we just knew it was a false alarm. Always a false alarm. But there was that one time that it was actually on fire. So you never know. You might get the person that calls because they have a stomach ache, and they always have a stomach ache, and it's the same thing every time. You get there 50 times, and it's not an emergency, right? You look at them, they're perfectly fine. Yeah, and not just homeless people. It can just be elderly, like elderly people that are by themselves all the time. Sometimes they'll call 911 just to have a human interaction for a little while because they never have any visitors or like no family visitors or anything, and it can be pretty sad. Sometimes yes, you'll get the druggies that are wanting to take a ride to the farthest hospital so that they can try to get some drugs, but that's really not the norm. It's just frustrating when it happens and it starts to feel like the norm because nobody wants to have to deal with those calls. So for scene safety, no, I'm sorry, yeah, scene size up, not scene safety. I'm jumping ahead of the slide. We're going to start with scene safety. That is your BSI scene safe. You're going to do that every single time. All right. If you walk in the room, now the way that we do it for your evals now is if you walk in the room and you put gloves on, that counts. So if you walk in, you don't say BSI, we're not going to fail you if you're wearing gloves. If you are not wearing gloves and you don't say BSI, then that's an automatic fail. But you want to make sure the scene is safe for you, your crew, and your patient. Hold on a second. My computer's wanting to do its own thing. There we go. All right. Use your standard precautions, which as of right now are still just gloves, but I'm noticing a trend in the training that we give that eye protection is becoming a standard protocol or a standard protection as well. Most of the video demonstrations that you see online now involve wearing glasses as well. So that's probably coming. Determine the number of patients and whether you need help, just like I said. So number of patients, additional resources. Determine the NOI, which is the nature of illness. And then we're going to get, at this point, a real quick signs and symptoms. You're not getting a full sample. All right. Seeing signs and symptoms at this point is pretty much just trying to figure out what their chief complaint is. You're trying to determine that NOI. So don't launch off into sample at this point, but just be like, what's going on? All right. And if it's a heart patient, they'll tell you, oh, my chest is hurting or something of that sort. For COVID, iPro and gloves and gown. Y'all are dressing to the nines on that one, huh? Is that I won't say the company name, but is that an ambulance policy y'all are doing, or is that just what you're doing on the truck? Oh, standard across the board. Okay, I got you. That's interesting. Yeah, we didn't have to do all that at the base. Of course, now that was earlier in the year, so policies have probably changed since then. Your index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries or illnesses. So you might get the patient that tells you, "Oh, I'm fine. I'm fine. It's just a little heartburn or something like that. I don't know why my wife called 911." And you look at the patient and they look like death warmed over. They're cool and clammy, diaphoretic, which is, remember, diaphoresis is sweating. Their pupils don't look right. They're short of breath, and you're like, man, you're full of it. You look like you're about to die on me, so I'm not buying what you're selling. And then initiate spinal immobilization if indicated. You typically won't have to do that for medical assessments, but we still want you to keep in mind that you may have to. And then, can anybody give me an example? I don't know if I've given y'all one in the past or not. What medical call might you need to put a C-collar on somebody for? Purely medical, not trauma, at least not trauma that you know of. A fall, okay. Falls are typically trauma. That's a good one. Seizures a good one. What else we got? There's a big one that comes to my mind because they beat this into us in paramedic school. Um, and I think that it's actually a really good point because a lot of people overlook this one. Think about a stroke. Why would you want to put, let's say you show up to an elderly person's house for a welfare check because the neighbors called 911. They haven't seen their elderly neighbor walk outside in a while. It's getting to be kind of cold. And they're just a little concerned. So they call you, you go over, knock on the door, no answer. You look in the window and you see this lady laying on the floor, seemingly unresponsive, in her living room. So you gain entry forcefully to the house and you go to take care of your patient. This person needs a C-collar. Why is that? Induced.
Patient could have injured themselves during the seizure.
They could have. All right. So it could possibly be a seizure. There you go. So, all right. So, Mike Allen, you pretty much hit it. We don't know if they had a seizure. They're just laying on the ground. It's an elderly woman. There's a possibility of a stroke. Let's say that, and I may even lead you down that road. I'll say like, all right, looks like your patient has had a stroke. There's no telling how long it's been. You don't know the extent of the injury. You don't know if she fell from a standing position. So, um, possibly in the neck. Good guess. C-collars are meant for trauma. But sometimes you'll find your patient in a position that you don't know how they got there. So there is always that possibility that they did hurt their neck when they fell, especially if it was something uncontrolled like a seizure or a stroke. Those can be reasons to put a C-collar on there. So those are some exceptions. Usually, if somebody tells you their chest is hurting, you're not going to put a C-collar on them. But if you can't rule it out, if you don't know, like if you see them laying on the ground, you can't rule out that they didn't hurt their neck, especially elderly, because their bones are so brittle. Then put a C-collar on them. That way, while you're moving them and going through the medical assessment, which doesn't really do much for C-spine and stuff, if they did in fact hurt something, you won't make it worse. All right. Let's see. For the primary assessment, which is the slide we're on now, you're going to develop a general impression. So we typically just say sick or not sick is the easiest way to determine your general impression. You look at a patient, and this is your opinion. This is not what they tell you. What they tell you is the chief complaint. That's why they called you, right? But your general impression is, what do you think just looking at your patient? If somebody is sitting there, like I'm sitting at this desk right now, and they say, my chest hurts, and I look perfectly fine to you, then your general impression is probably going to be not sick, right? But if you see a guy sitting there in a chair and he's, like I said, he's clutching his chest, sweating, grimacing, has his skin looks weird and all this stuff, and it doesn't matter what he says. He might say, I feel fine, it's just a little heartburn. That's what he says. But your general impression should be, this dude is sick. Like he's naive, but I don't know what it is, but he don't look right. So you're going to do that, and that's fast. You should be able to develop your general impression within the first second or two of seeing your patient, because you're only looking at visual, the signs that you can see. So visual clues, their apparent level of consciousness is one. Any obvious severe bleeding, so if they have an arterial bleed or a bad venous bleed, difficulty breathing, anxiousness kind of goes back into their level of consciousness. Any of those 30 things can really give you a quick, this guy's circling the drain. Look at their other circulatory signs. Every time we talk about circulation, we're always thinking about the pulse and the blood pressure, but their skin is a fantastic way to know what their circulation looks like, because if it's cool and clammy, which is kind of gray and looks like they're kind of like glistening because they've got fluid seeping out of them, that's usually a sign that they're not perfusing properly. If they had good perfusion, then their skin would get a blood flow, but because there's no blood going to the skin, that's why they're cool and clammy, and that's a sign of some kind of shock typically. And if it's medical, then it's probably not bleeding that's causing it. It could be anything else. It could be distributive shock. It could be anaphylactic shock. Any of those things. So that you're going to go into your assessment and try to figure that out, because your treatment's going to change depending on what the problem is. Quickly determine the patient's level of consciousness using AVPU. Again, like I was saying before, you can do a GCS, especially if you're good at it. But at this stage of the game, just get them into one of 4 levels and base your treatment off of that. If they're unresponsive, check a pulse, make sure you don't need to do CPR. If they're any of the other 3, then continue through your assessment accordingly, starting with your ABCs. Speaking of, A and B, airway and breathing. So we want to basically just make sure that our patients have a good route to go from their mouth and nose all the way to the alveoli in their lungs. All right, so we're going to do a head tilt chin lift if there's no trauma, or at least if there's no neck trauma. Do a jaw thrust if we need to. Check their respiratory rate, depth, and quality. So again, we breathe at 12 to 20 times a minute as adults. It's not so much that we're breathing at the right rate. We got to make sure that the breaths are worth a damn as well. So they got to be a good depth and a good quality. Equal rise and fall of the chest. If you don't see that, if it looks really shallow, then the numbers are going to have to change because it's all about that minute volume. We can't compute that in the field, but you can kind of eyeball a patient and say that doesn't look like good breathing. Consider applying oxygen, and then for unconscious patients, use your proper airway technique, either jaw thrust or head tilt chin lift. And if they are unconscious, they need an adjunct, an OPA if they can take it, an NPA if they can't. You're going to apply oxygen to any patient that's in shock. We can't stop shock, so whatever we can do to slow the progression of it, the better. If you see them with difficulty breathing or an altered level of consciousness, they're going to get it. And then when we get to the vital signs, if their O2 is less than 94, you're going to give oxygen as well. Again, we don't bother with an SpO2 in their initial. So when you're at the AB stage, you're not going to have that percentage. So that shouldn't factor. But when you get down to the vital signs, if you're like, oh, this dude's rocking at 88%, maybe I should give him oxygen. Consider that. Unconscious patients may need airway adjuncts. We already said that. And then if they are unconscious, you are probably going to have to bag them. A lot of times patients aren't going to be breathing perfectly when they're unconscious. C for circulation. Assess the circulation in a conscious patient by checking the radial pulse and observing the patient's skin color, temperature, and condition. So we already mentioned that. And then if they're unconscious, you can check for the carotid. I personally like to see people feel for both pulses at the same time, because you can lose the pulse in the wrist and still have a pulse, right? You can have one in the you can have a carotid pulse, but not one in the radial. So if somebody's unconscious and you waste 10 seconds trying to find their radial pulse and they don't have it, and then you go to the carotid pulse and you waste 10 seconds trying to find the carotid pulse and they don't have it, it's that much longer before you actually say, oh, maybe I should do CPR. So I just tell people, get in the habit. You got two hands and you only need two fingers to find a pulse. So one on the neck, one on the wrist. Not only are you determining in one fell swoop if they're going to have good circulation or if they have like a good pulse and good perfusion, but if those two pulses are out of sync with each other, if you're feeling a definite delay between the pulse in the neck and the pulse in the wrist, that tells you that you have a cardiac problem that you otherwise would have missed if you only checked one at a time. And we'll get to that. There's a chapter for cardiology. I'm going to bring up that so you guys can catch it when we get there. That's just something they don't really teach. So I picked that up from a cardiologist. I thought it was a really good idea, and it'll be good for y'all to know it. Once you get through your ABCs, you're going to make your transport decision. Every patient you get in class and in your evaluations is going to be a high priority for transport. We're not going to give you a stubbed toe for an evaluation or even practice in class. Everything is going to be an unstable patient, critical patient, because we want to see you go through all the steps. I want to see you hit everything. And if you roll up on a patient, I mean, Wesley can tell you, and any of you guys that work in the EMS, you roll up on a patient where somebody said they just stubbed their toe on the table. You're not going to take C-spine precautions and do a head-to-toe assessment when all they're complaining about is a possible broken toe. You're going to help them onto the stretcher, wheel them out to the truck, and leave. So, that being said, yes, for the class, everything will be a high priority for transport. But that being said, in the real world, not everybody is that way. So the following patients should be considered in serious condition and in need of rapid transport. Patients who are unconscious or have an altered mental status. If they aren't alert and oriented, there's something seriously wrong, even if you can't see it. They need to be a high priority. Patients with airway or breathing problems and circulatory problems. If there's a problem in the primary, they need to be a high priority for transport. So again, that being said, we're talking about the major issues, right? A paper cut or a broken bone, those aren't high priority decisions. But if they had an arterial bleed, if their pulse doesn't feel right, if they're not breathing right, those kind of things make them a high priority for transport. So if the patient doesn't meet the criteria for rapid, continue your assessment on scene and prepare for transport, but keep an eye on your patient, because if they start to degrade, you may change your mind. You may get there and they may not meet your criteria for high priority. But especially if they're starting to develop shock, they're going to deteriorate through the course of your call. So keep an eye on that. If you see them starting to get worse, you might want to pick the pace up and go and throw them in the truck and go. For your history taking, determine what the problem is or what may be causing the problem. All right, so now we're going to start getting into the questions that we ask our patients. All right, like I said, know your sample, know your OPQ-RST. You're going to get a thorough history. If you can get it from the patient, great. Not always the case. Sometimes if they may be unconscious or somehow incapacitated, and you're going to wind up having to get it from family or bystanders. If there's nobody there, then you just can't get it. So if that's the case, if I give you, because I may do that, we may give you a scenario where all you have is your patient, there's nobody else there, and they're unconscious. So therefore, you're not going to get a sample history or an OPQ-RST. And basically what we're doing is sometimes we'll start with those because we want to see you just get through the assessment. And then we'll start to add more in so that you have to do more. But even if that's the case, I want you to get used to saying, you know what, I would ask for my sample, but there's nobody here. That way I know you at least thought about it. Or I would ask for my OPQ-RST questions, but the patient's unconscious. Only the patient can answer OPQ-RST, right? Because they're the only ones that know what they're feeling. So if the patient's unconscious, you can go ahead and toss out OPQ-RST. You're not going to get it. But as far as sample goes, you can get that from bystanders if they happen to know the person. If the person is unconscious, survey the scene for medication containers or medical devices. Where are some places that people tend to keep their medicine? Any of y'all that have been on 911 calls or even in your own family, where do y'all purse? All right, purse is a good one. Nightstand, pantry, side of the bed. All right. What about insulin? What if your patient is okay, there we go. Corey, okay, good. I was going to see if anybody was going to mention that. Check the fridge for meds. Insulin and other hormone injections like that have to stay cold. So a lot of times they throw them in the fridge. If they get too warm, they start to break apart. They don't really do what they're supposed to do. Good. All right. So again, sample and OPQ-RST, we already talked about that. I guess I jumped the gun a little bit on those. But just remember, only the patient can give you OPQ-RST. So if I tell you that somebody's, it's like, oh, the mom's standing there. Don't ask the mom what the pain feels like because she really doesn't know. Record any allergies, medical conditions, and medications. Even if it doesn't apply to your treatment, the hospital is going to want to know that stuff. And then some patients take numerous medications, especially the older they get. Some people will have an entire shoebox of stuff for you to dig through that, just that alone could take your entire trip to the hospital. All right, now here's a new mnemonic, and this is one that I haven't actually memorized. I've never seen this on the registry, but it probably wouldn't hurt for you to at least be familiar with it. The mnemonic tacos can be helpful in identifying conditions that may be complicating a patient's chief complaint. So these are things that can either render a medication inert. They could be synergistic with medications. They can be masking pain that you would think they would be feeling pain, or rather changing vital signs that shouldn't be getting into the ranges that they're getting into, and so otherwise just make your assessment not make sense. The more you do it, the more you're going to start to learn those triads, like Beck's triad, all that stuff, where if they have a head injury, these three vitals will always do this, unless they're on heroin, and in which case they're not going to do that. Or if they're on a beta blocker, then the heart rate's not going to rise and that kind of thing. So it throws off those combinations that we normally see in people's vital signs. So tobacco, alcohol, caffeine, these are stimulants and depressants, over-the-counter medications, herbal supplements, and then sexual and street drugs. Some prescription drugs, like I said, beta blockers. What do those do? So if I told you that a beta blocker was a beta 1 antagonist,
Heart.
it's the heart. Good. Beta blockers operate on the heart. And what they do is they basically put a glass ceiling over your pulse. So as long as you're taking your beta blocker, um, your pulse should not get out of hand. It shouldn't climb. And that being said, if you're looking at a patient's shoebox or medical history or whatever, um, it's not enough to know what your medication, what your patient is prescribed. Make sure they took it and that they took the right amount and when they took it and stuff like that, because some of those medications people will forget to take them or they'll take too much, um, and that can play into it. So, your patient's on a beta blocker, great, but if you hadn't taken it in 3 days, it's not going to do them any good. The fact that it's sitting in that pill bottle doesn't mean anything. Or if you look at a pill bottle and it says it was filled 2 days ago with a 30-day supply and the bottle's empty, that's another problem. Scan the scene for clues about the patient's medical history. Sometimes they won't be so forthcoming if it's something embarrassing, so they may not want to tell you, but that's just something you kind of have to deal with. A lot of times you may not find much, but if you see, like I said, insulin injections, for example, you see needles laying around from where they've been injecting insulin, that would tell you that they're a type 1 diabetic. And that's something that's important if they're unconscious. Typically, they're not going to have a problem telling you that, but there's some like FTIs and sorry about that. With my AirPods not working, y'all get to hear everything happening around me. All right, so where was I? Secondary assessment. So we made it through our primary, we've made it through our history taking. Now, again, my dog wanted attention. He dropped his ball behind me. I didn't turn around, so he barked at me. That's just how it works with Princess. Um, so anyway, I personally like to put the history taking in the secondary. I consider the secondary assessment to be pretty much everything after the primary and before the ongoing. And then how you structure your secondary assessments up to you based on whether your patient is critical or not. But other than your history taking, the secondary assessment can either occur on the scene or en route to the ER. So it just kind of depends. If your patient is critical or unstable, don't waste time at the scene. Put them in the truck and leave, and you can do this stuff on the road. If it's not that big of a deal, you can do stuff at the scene. A good example would be a diabetic emergency. We typically don't transport diabetics that are known diabetics because we can fix them on the scene. But sometimes it's not the case. So for your physical exams, all conscious patients should undergo a limited or detailed physical examination based on their chief complaint. So you're not going to skip this altogether, but you don't, like I said, you don't have to do a head to toe assessment where you poke and prod every part of their body just because they stubbed their toe. And then for unconscious patients, however, if they can't tell you that they only hurt a certain body part, it will be a head to toe assessment because we don't know, right? We don't know if it's just a stub toe. So a lot of times, if they're unconscious, you're in for the long haul. You really can't cut anything out of your assessment. So for your head to toe assessment, even in medical calls, if they're unconscious, you're going to do the head to toe. So you're going to examine the head, scalp, face, neck, all the way around, not just the front. Check their chest and abdomen, palpate the legs and arms, patient's back, just like a trauma assessment. What's something that we might look for other than, because let's say it's a medical call and they're unconscious. We don't see any obvious signs of a real trauma. Say they're laying in the yard. What would be something that we would look for that doesn't fit the DCAT BTLS? It's not anything that would be in that acronym. But you just found a guy unconscious in the yard and you're going to do a head to toe assessment on him. What's something you might want to look at or look for? Track marks, yeah, that's one. All right, what else? All right, trauma. Yeah, I mean, that's ultimately what we're looking for, but think about it from a medical standpoint. Okay, you can look for small amounts of blood, right? You are going to rock the trauma chapters. Vomit, there's a medical one. If I'm doing a head to toe, like I said, let's say I found a patient unresponsive in the yard, and I'm going to do a head to toe assessment. Um, from a medical standpoint, if I don't see any outward signs of trauma, I'm going to be looking for medical things that could be causing my patient to be unconscious. So I will look for bee stings. Um, I will look for rashes, any signs of an allergic reaction. I will look for powder. Let's say that this person was putting out some pesticides, um, like some pretty hardcore pesticides to try to, you know, keep everything out of the garden or something like that, and they got it on them. Some pesticides will cause the heart to almost slow to a stop, which is, what do we call that? If the heart gets too slow, what's that term?
Bradycardia.
Bradycardia. Yeah, snake punctures, snake bites. You're looking for things like that. So even though you're doing a head to toe, again, being a medical call, we're not necessarily concerned about DCAT BTLS, right? Deformities, contusions, there's no real sign of trauma. So we're not going to look for the signs of trauma. We're going to look for things that could be causing medical issues. So think about what we talked about, the different types of medical emergencies we got. We have allergic reactions, we have toxicological emergencies, things like that. Some pesticides will really, really rock down your heart rate. Um, and there's a medication that is given for that. We don't do it as EMTs. The paramedics give it. It's called atropine. Um, but that being said, if you show up to somebody and you see a whole bunch of powder on them and they're unconscious on the ground and their pulse is only sitting at like 30, then that's that was the purpose of the head to toe, is you're looking for the things that could have knocked them out. Gases, yeah, if they're unconscious in the house, could be carbon monoxide, empty pill bottles. You guys are getting it now, so good. All right, moving on. Vital signs. And I'm going to get through vital signs, and when we hit reassessment, I'm going to take a break. So when we check for vital signs, and we do this in the secondary, now you're going to get your full set of vitals. All right, you kind of touched on it in your primary. You got a pulse. That's a vital sign. But you really weren't concerned about a number, at least not an exact one. In the primary, we only worry about, is it good enough to keep them alive? All right, so you don't even really have to get a number. You can be like, am I sitting at 1 a second? Am I sitting at less than 2 a second? That's good enough for me. But at this point, now we're going to get the real full set of vitals. So pulse, breathing quality, blood pressure, pupils, all that good stuff. O2 sat, you're going to actually get a number for it. But again, the vital signs are not just numbers. Okay, so we're looking at the numbers, yes, but we also want to get some kind of context to them. They're breathing 16 times a minute. That's great. Are they good breaths? We have a pulse of 100. It's a little quick, but it's still normal. What does the pulse feel like? Is it weak and thready? Is it bounding? Remember, your pulse and your breathing tend to work together. So are you tachycardic but breathing too slow? Are you the other way around? These are the kind of, it's not just the numbers. So I want you guys to keep that in mind, that you're basically looking to make sure that the quality is there, not just the quantity. Okay, so every ambulance that's got ALS support or capability has an EKG. You as an EMT, unfortunately, by the book, can't use it. You got me on why that is. I mean, it's not like the only thing you can do is turn it on and then try to interpret a 12 lead. There's so many things you can do with a monitor that is well within the basic scope, but the monitor itself is out of your scope, which is complete asinine, but I don't have any authority in that. So you're going to get your pulse, get your breathing, get your blood pressure. and then consider obtaining a glucose. If they are unconscious, you absolutely will get a glucose. If they're in altered level of consciousness, even if they're up walking around, if they're not in their right mind, get a glucose level, because it could be that they're drunk. They might have just walked out of the bar, but that doesn't mean that they're drunk, right? They could have walked in, sat down. They might have been the designated driver. We don't know. And then they had a diabetic emergency. So if they're not in their right mind, get a glucose. All right, take a 10-minute break. Be back at 8. No, I'm sorry, I'm back in Eastern time. 7:17, and we'll continue with the reassessment and go from there. And I apologize for all the background noise. All right, moving on with the reassessment. So once you've made it through your full assessment, we can't just stop there. Right. Now we'll sum up the reassessment very, very quickly here. I'm not going to beat it with a bunch of slides. Uh, we want to keep track of trending for our patient, especially if they're going to degrade on us, because I don't want to have somebody go into cardiac arrest halfway to the hospital and me not see it. Um, so we reassess our patients. If they're stable, we do it every 15 minutes. If they're unstable, we do it every 5 minutes. That being said, you're always going to do it. You're always going to get unstable patients in class, so you're always going to do the reassessment every 5 minutes. Um, just know that real world, reassess every 15. That's perfectly fine. The 5 minutes also coincides with the 5 minutes of CPR. So, no, so not CPR, but the medications that are given with CPR. Um, it's just 5 minutes is pretty easy to remember. So if you are working with a paramedic and you're doing a code, you're going to be doing CPR. He's going to be pushing meds and working the AED and all that stuff. So he's going to shock, and then 2 to 3 minutes later, he's going to give a med. Then 2 to 3 minutes later, he's going to give a shock. Hey, that's been 5 minutes. Get a quick set of vitals. Um, see how it's working, pretty much. So what we reassess, we're going to be reassessing their vitals first of all. Reassess your ABCs. Reassess the chief complaint. See if they are still hurting as bad as they say they were when they got there, or if the pain's gotten any better. Reassess their any interventions that you've done. So if they're unconscious and you had to do, say, like, I don't know, put a tourniquet. Let's say we'll jump into trauma just for this example. Let's say you had to put a tourniquet on somebody. It's a good idea to make sure that that tourniquet hasn't slipped, hasn't started failing, where blood's starting to come through. May not be bad enough to spurt across the ambulance, but it could be they could be starting to lose blood again. So these are the kind of things that you want to reassess when you check your patient. For medical calls, obviously you're not going to really be dealing with a tourniquet, but you get where I'm going with that. Reassess to make sure that they're still holding a good O2 sat, because if for whatever reason their lungs start to fill with fluid, then they're not going to get that oxygen exchange. All right, for the management, your transport and destination. Most medical emergencies require a level of treatment beyond that's available in the pre-hospital setting. Some things we can fix. Some things we can fix as EMTs. Some things we need a paramedic for. Diabetes is typically treated in the field. It's not that big of a deal. But and that's type 2 diabetes, by the way, not type 1. Type 1, we really can't do anything with that in the field. Unless they've gone to hypo because they put too much insulin in their system. Sometimes you can fix that. But hyperglycemia from a type 1, we really can't do anything because we can't administer insulin. Not even a paramedic can't do it either. They need that really fine-tuned control that's in a hospital. So they may require advanced testing, getting lab work done, getting blood drawn, all that stuff. So we really ultimately need to try to get them to a hospital unless it's a call that just doesn't need it. Some things may be beyond your scope, and some things are within your control. Like I said, it even says it down here at the bottom. EMTs can use an AED. You really technically can't use a manual because we don't teach you how many joules to set, right? Paramedics know and they have control over how much electricity they want to put into a patient, but we don't teach EMTs that. So you guys use the AED like a firefighter would, which a lot of times is perfectly fine. There's nothing wrong with that. If electricity is going to fix a patient, the AED will typically do it. So those are some really good things that we can do to hopefully get people back. How can they use an AED but not do an EKG? I'm not following. Remember, an AED and a manual defibrillator are two different things. I'll say this. Okay, I was about to say. So EKGs are visual representations of the electrical impulses of the heart. All right, you're actually looking at the waves, but if you haven't been taught what those waves look like, um, and then how do you know when something's wrong? Now, we do teach you a couple of, um, I do teach you a couple of strips in class because I want you to know what VFib and VTAC look like because those are the shockable rhythms. But as an EMT without a monitor, you're not going to see those rhythms. So what we rely on is the AED. The AED does the interpretation for you. So you don't actually look at a strip and say, oh, you have VTAC, I'm going to shock you. You put the pads on the patient. And in the AED, the way that those work is it will say, all right, I can shock two things. Is this VTAC? If yes, cool, it'll shock. If not, then all right, is it VFib? If yes, cool, it'll shock. If not, no shock advised. It doesn't diagnose anything. It just looks for those two rhythms, and if it sees them, if it sees either one of them, it's gonna tell you to shock. Seems like a STEMI should be recognized by an EMT. I would love to agree with you on that. Um, it's just that all right. So having been trained to find a STEMI, it is definitely that one topic is harder than the entirety of this class. I'll say that. There's so because then we're going to go over Scarbosa criteria, and there's a whole bunch of other terms, and you got to learn how to read the 12 leads, um, because that STEMI can be anywhere in the heart, not just what lead 2 can see, which is what most people look at when they think of a single line of a EKG strip. It is pretty difficult actually to find a STEMI. That's a paramedic's bread and butter, but they get that beat into them in school for well over a month, just that one topic. Just wondering, are there services without Zoll, etc.? Are we referring to volunteers or something? So, all right, Zoll's a brand. Um, so yes, there are definitely services out there that use other things other than Zoll. There's Philips Heart Start. A lot of places use those. Um, there's a few others. You see, a lot of times you see Philips up in the north. The military uses, or they for a while they used Philips. We used Zolls when I first came in as a medic, and then we switched to the Philips Heart Start. Found out it was a piece of crap, at least the models that we got, and then so we went back to Zoll. But yeah, there's other brands out there. It's not just Zolls. Uh, all right, so where were we? Scene time, maybe longer for medical patients than for trauma patients because a lot of times we're trying to figure out what is going on. We're going to ask more questions. A lot of times that means being on scene longer, that kind of thing. Whereas trauma patients, you'll be like, oh, he got run over by a car. All right, let's do a quick head to toe, put him on the board, get him in the truck, and leave. Critical patients always need rapid transport. And also, if they're very old or very young, it may not be that bad of an issue for an adult, but if an altered level of consciousness or a fall, like we've talked about falls a couple times, that was mentioned tonight. Somebody falls from a standing position and they're 30, that's not a big deal. Somebody falls from a standing position and they're 73, that's a big deal. All right, so they will be a rapid transport. If a life-threatening condition exists, the transportation should include lights and sirens. I'm going to actually tell you guys to defer to your protocols for that one because, for example, if it's a cardiac emergency, a lot of agencies don't want you to do lights and sirens because it raises the anxiety of your patient, which raises the workload on their heart because you raise their pulse. If the patient is stable enough with the paramedic that you can go without lights and sirens and it's a cardiac patient, that may be the best thing, right? We're going to do what's right for the patient. You could exacerbate and speed up the process of cardiac arrest if you're not careful with that. So take that particular slide with a grain of salt. Talk to your agency, and I mean they'll tell you in your training whether or not they want you as a driver to go lights and sirens. Wesley, what do y'all do if it's an active heart attack? Are you lights and sirens to the nearest hospital, or do you guys kind of keep the lights off, keep the patient calm? Yeah, okay, that's what I was thinking. Yeah, so anything you can do to stop the patient from raising his pulse or upping his blood pressure because you're kicking in his fight or flight response is better. Modes of transport ultimately come in one of two categories: ground or air. Air, depending on where you're at and where a lot of you guys are, is not that common. I think there's only two helicopters in the entire state of Mississippi. You don't do lights and sirens for syncope. No, and again, yeah, because that could be cardiac related, and you could make the situation worse. Ground transport EMS units are generally staffed by EMTs and paramedics. If you get into the major cities, like Buffalo, um, oh, you do for a heart attack. That's interesting. Like I said, it's agency dependent. The last ambulance company I worked for, we did not. We were like driving Miss Daisy if it was a heart patient because we wanted them to be as calm as possible. And there's a lot that a paramedic can do to kind of prolong it. I mean, if you've got a 45-minute drive to a hospital and your lights and sirens whipping through traffic for 45 minutes, that's going to take a toll on your patient. Anyway, a lot of your bigger cities whether they can't afford to or they just don't want to, they will not put in a paramedic on every truck. So what they typically do is they will make most of their units or all of their units, like what you see in this picture, will be basic trucks. And then they'll put their paramedics in sprint cars. So your scene size up is very important when you show up on a scene and you're considering what's in front of you, and then you consider the need for additional resources. It very much well may be that you need to call a paramedic to come over there to provide ALS. Louisiana has Acadian and Pafford and Air for helicopter. That's good. Yeah. Yeah, you guys have a good bit. I think Mississippi has Rescue 7, and I think that might be it. Life Air, is that in Mississippi? I know they had it was either Lifeguard or Life Flight or something, but I can't remember if they're still there. So that's good. Helicopters are becoming more common. They are. I know that when I first became an EMT, we had Rescue 7, and that was it. That was the only helicopter for Mississippi. And if it was cloudy, they didn't fly. So a lot of times we didn't have access to them regardless. Your air transport, though, they're usually really, really well trained. One of our other instructors here at ARES is actually a flight paramedic for Rescue 7. He's critical care air transport, got his flight paramedic stuff. He's got certifications. I don't even know what they are. So we're glad to have him, but he's a good example of what kind of caliber of training gets on those helicopters, because it's cramped quarters. They don't get the small calls, right? You're not going to call a helicopter for a stub toe. You're going to call a helicopter for the person where you're sitting there looking at him going, what do I do with this guy? So they have to be able to handle those. All right, and now destination selection, and I want to talk about this for a second. I'm not going to make you guys masters of trauma regions and things like that, but I know me and Wesley were having a conversation about this a little while back about choosing the hospital that you're going to go to. If your patient's unstable and you can't stabilize them in the ambulance, then your transport decision is going to typically be the nearest hospital, because no matter what level of trauma they are, they should hopefully be able to help you stabilize the patient at least long enough to get them to a better hospital. A good example of this, and I can put this into South Mississippi terms because that's where I used to work. We had a hospital. For a while there, this hospital didn't even exist, so it was easy then. Poplarville, Mississippi currently has a barely there hospital. And I'm not talking about their training, I'm just talking about their capabilities of what's in the building. They really can't do a whole lot. So if it's an unstable patient, if it's a bad patient, we will go there, or they will go there typically just to stabilize the patient and then leave. If it's a stable patient, they won't bother stopping there, because those kind of hospitals exist to help stabilize patients and then move them up to the trauma centers like Forest General. So if you have a patient with a broken leg and you've controlled the bleeding, and you show up to Poplarville, they're just going to look at you like, what do you want us to do? And you're going to get back on the road and go to Hattiesburg. If you have a cardiac arrest in Poplarville and you show up to the Poplarville Hospital, they're going to be like, cool, bring them in. We have nurses here and everything. And then they're going to help you run advanced life support, try to get ROSC, which is return to spontaneous circulation, hopefully get your pulse back. And then you take them on to Forest General, which is a level 2 trauma center. And they've got doctors out the wazoo that are specialties, and you've got your neurologists are there, and so on and so on. Or if it's a lost cause, because we've had those where the patient is just not going to come back, there's a doctor at that hospital that can call it. So you don't spend 45 minutes driving up the road doing compressions to get to the nearest hospital. So you're going to make your transport decisions based on what do you need? Do you need help stabilizing the patient? If so, go to the nearest hospital. Is the patient stabilized enough that you can pass that hospital and get them more definitive care? Then good, do that. Infectious diseases. Actually, let me back up before we get into this. Also, as an ambulance driver, or EMT or whatever, if you're the one moving the truck, you can't take a patient to a non-emergency room. So if there's a hospital in your area but they don't have an emergency room, you can't stop there. Okay, the ambulances go ED to ED. And you make your decisions based on that. So unless med control is telling you to do so or whatever, you're not going to take your patient to the urgent care. That's just not your role. Unless, like I said, if you're explicitly told to do so, well, then you do what you're told by dispatch and let it be their problem. But your own decision making is not going to include those. All right, infectious diseases. So approach the patient with an infectious disease like any other medical patient. Don't treat them like they have the plague unless they have the plague. And even then, remember, keep their dignity in mind. Perform your scene size up, take standard precautions, and complete your primary assessment. Just because somebody has HIV doesn't mean that you're going to get HIV for being in the same room with them. Just pay close attention to what you're doing, especially if you're around needles and something that can do a bloodborne pathogen transfer to you. Get your patient history using OPQRST to elaborate on their chief complaint, especially if it's pain related. And typical chief complaints include fever, nausea, rash, pleuritic chest pain, which is, what is that? Somebody tell me what pleuritic chest pain is.
What'd you say again, Robert?
Pleuritic chest pain. There's a couple things that can make the chest hurt. What is pleuritic? See if it's on the next slide. Nope, it's not. So it's not written. But if it's pleuritic in nature, that means it hurts to breathe. It's something to do with their lungs. It could be pleurisy itself. It could be pericarditis, which is putting pressure on the lungs and it's hurting to breathe. It could be any of that kind of stuff. So that is something to keep in mind. All right, that's common because a lot of chest issues can lead to that. Difficulty breathing is very common. So is vomiting and diarrhea. And remember, nausea and vomiting typically go together. So if you have a patient that tells you that they're not nauseous, but they're throwing up all over the place, that is considered a pertinent negative, and that's important because there's only a few things that will make you vomit without having nausea first, and they're typically to do with head injuries or some kind of intracranial pressure. Obtain a sample history as long as your patient is alert or bystanders know. And ask whether the patient has recently traveled or has come in contact with someone who has traveled to other countries. And it's not just, I mean, we hear that all the time, especially with COVID, but it's not just COVID, right? We had, if you think back a few years with the Ebola issue, it was the same thing. And had you traveled to West Africa or been in contact with somebody that had traveled to West Africa, that is to help in tracking if we're having an issue with another country that's got an Ebola outbreak or a COVID outbreak or something like that. We're trying to figure out if that might be something that you're at risk of. So for the general management principles, Focus on your life-threatening conditions first, just like any other assessment that you're doing. ABCs come before the secondary. Be empathetic. Um, Place the patient in a position of comfort on the stretcher. Keep them warm. Use your standard precautions. Like I said, don't treat them like they got a third arm. Don't look at them like they got a third arm. A sickness is a sickness. If it's the cold, if it's Ebola, as far as what's going wrong to them, it's the same. All right, treat it the same. Give them the same respect, the same dignity. Just be careful. You don't want to catch the cold from somebody. You don't want to catch Ebola from somebody. And if you do happen to get stuck, if there's something that happens, say that your paramedic gave him an IV and then you were trying to discard the needle and you hit a bump and suddenly you stabbed yourself with the needle. Follow your agency's plans on how to do your exposure reports. Epidemic and pandemic considerations. This ought to be fun. So for an epidemic, when new cases of a disease in a human population substantially exceed what is expected, that's considered an epidemic. And then a pandemic is an epidemic on steroids. That is a disease outbreak that occurs on a global scale. So when COVID hit all inhabited continents, it became a pandemic. But an epidemic, everybody usually you hear epidemic and you think that that's the bad one, right? I was like, I think that movie Outbreak, they kept saying epidemic, epidemic. That's really not always that bad. It just means it is worse than they expected it to be. So a flu season where the flu vaccine that we get doesn't work because it's a best guess. We base our flu vaccines based on the last year's outbreak in Australia or something like that. Is not always accurate. So there are times where our flu vaccine for the year was kind of a waste because it was the wrong strain. And then we have a much bigger flu outbreak that year than usual. That would be an epidemic. Speaking of influenza, this is a serious communicable disease, but it's very common. So this is the flu. It's an animal respiratory disease that is mutated to infect humans. This is basically like a cold on steroids. Typically, you feel like you got hit by a truck, and this does kill people. This is pretty serious. Um, but with good medical care, even if you get it, as long as you go to the doctor and you get treated for it, typically you're okay. There are some versions of this that are pretty gnarly that we don't like to mess with, like H1N1. Um, Initially identified as a swine flu. This was back in Obama's term. If you guys are remembering the news and stuff like that, he got hit with this, or he had to deal with this pretty early in his presidency. This was initially identified in 2009. It caused a lot of deaths, and it increased awareness of the routes of transmission. For diseases that can be passed by the respiratory route, always wear PPE. Obviously, your gloves are not going to stop you from getting a respiratory disease, but the right mask will. If it's something that is passed through body fluids or any kind of physical contact, wash your hands frequently. Place a surgical mask on patients with suspected or confirmed respiratory disease. So a surgical mask is not going to stop TB, but a HEPA filter mask will. But at the same time, even that comes with the fact that typically the mask has to be fitted. You should be fitted for a HEPA filter or an N95 mask. I keep saying HEPA filters, that's what they use, but an N95 mask should be fitted to you, just like firefighters get their mask fitted to them every year. If it's not fitted properly to you, then it may not work. So keep that in mind. All right, yes, you can absolutely throw a mask on the patient. But if it's an airborne, like a true airborne illness like TB, I would personally put a mask on myself as well, just to be safe, because you don't know if that mask fits that patient. Herpes simplex, there's type 1 and type 2. Type 1 is around the mouth. You can get that from drinking or eating after somebody. Silverware that's not washed all the way, that kind of thing. It is typically what causes the sores around the mouth, like fever blisters. Type 2 is the STI version of that, so it's around the genitals. Symptomatic infections cause eruptions of tiny fluid-filled blisters called vesicles that appear on the lips or the genitals, depending on your type. Here's a scary one for you. Of individuals carrying the virus, 80% are asymptomatic. They have no idea they have it. This can cause more serious illnesses in susceptible patients. So if you're immunocompromised and you get this, you're going to be even that much more susceptible to getting sick. Primary mode of infection is through close personal contact. Again, it's not just STI. There's a whole other half to this. The good thing is though is that the body tends to kick type 1. Type 2 is a little bit more stingy, but type 1, your body can kind of get rid of it after a while. HIV, this is a blood-borne illness. This is actually, a lot of people are afraid of HIV. HIV is actually a pretty weak virus. It doesn't last outside the body. It's got a very short temperature range that it can live in. So if it's a direct blood transfer, like let's say you had an open cut, and your patient had an open cut and they had HIV, and their blood coming out of their skin, you got it on you and it got into a cut on you. You're at a high risk of getting it from that. You can get it from needle sticks, but the longer that blood is outside the body, the more likely that the HIV virus is dead. So if you do get stuck by, let's say, a needle that was in a patient's room, all right, you go into a room, because I've had this, I didn't have the needle stick, but I've had these patients where you go into the room, somebody that knows the patient says he's an HIV patient, and then you go to move the patient and you see a needle sitting on the table. Say he's on drugs, or he's also a type 1 diabetic, because you can have more than one disease. If you stick yourself with that needle and let's say you used it a while back, chances are the HIV virus is already dead. It sucks you got stuck with that needle, and that's a scary, scary thing. But take solace in that if that needle was used on the patient 12 hours ago or even 1 hour ago, your risk of getting infected is actually kind of low. So don't be deathly afraid of HIV. I don't want you to be afraid to walk in the room with somebody that's got it. It's pretty hard to get it from somebody, even though it can happen. So you are at risk. There's no vaccine. We do have medications that can stop the progression to AIDS, but it's pretty much at this point, it's pretty much a lifetime. You're going to be taking the pill every day or something like that. You can't kick it, but you can stop it from getting worse. This is not easily transmitted in the work setting, like I was saying. So your risk is pretty limited. Many patients with HIV don't show any symptoms. What HIV does is it actually starts to just weaken your immune system. So you won't see direct symptoms of HIV. You're just going to start to notice they get sick more often, and then they get sick more often and more often, and eventually they develop AIDS, and then that's where the death sentence starts to come in. Just wear your proper PPE. Try not to get stuck by anything, and you should be good from there. Hepatitis. There's a bunch of different flavors of hepatitis out there, and they're designated by letters. So you have hepatitis A, B, C, D, E. I think there's even more than that. Some are worse than others. Some of them are easy to get, but they're also easy to kick. Not all of these are permanent. Hepatitis by itself just means inflammation. I was going to ask y'all, but it's right there on the slide. Inflammation of the liver. There are some early signs that you can see. As you can see them on the slide, I won't read them all off, but a couple of them that you see commonly is your loss of appetite, your vomiting, because it's affecting your digestive tract. Fatigue is big. When it starts to get really bad, you'll start to see jaundice, which is where the skin turns yellow. But that's a little bit later of a sign. Like it says there. Right upper quadrant abdominal pain. So remember, your liver is in the right upper. All right, your spleen is in the left upper. So if they're complaining of major pain to an upper quadrant, those are two big things that it can be. And also those two organs, your liver and your spleen, are also very, very vascular. So if it's trauma related, you have a risk of very high blood loss that's internal. If it's the spleen, you also have the risk of um, sepsis. So keep that in mind. But on the liver, toxin-induced hepatitis is not contagious. That is, I'll tell you what. Let's see. Anybody in here know which hepatitis flavor is toxin-induced? What the main one is, at least, when you see the most? It's not C. C is actually contagious. You can get Hep C from people. I don't think B is. There you go. Crystal got it. Hep A. Hep A is common in undercooked meat. In fact, there was a Mexican restaurant, thankfully not the one that I go to all the time, but there was a Mexican restaurant that got put in the news because a whole bunch of their customers got hepatitis A because the restaurant would leave their beef out overnight. They wouldn't put it back in the freezer. And then they come in the next day, the beef has long since been room temperature, and they would just use it to cook more food. So I don't remember what the restaurant was. They got shut down for it, so you guys aren't in any danger of them, but that's just something to think about, right? That's why we have to take care of our food. Our body is we're kind of susceptible to hepatitis. The good thing though, like I said, that's actually a kickable hepatitis flavor. So Hep A, you'll get it from that. It sucks. You'll go through some symptoms, kind of like the flu, and then your body gets rid of it. So you're not contagious if you get it, and unless you're immunocompromised, typically you do get rid of it. But that's just scary to go to the doctor and then tell you they have hepatitis. It's because you ate some bad Mexican food or bad any food. And that's not that I use them as an example because they were in the news for it, but it's not just Mexican food. There's no way to tell which hepatitis patients are contagious. Not to you as the EMT. We do have a vaccine for Hep B. It's a 3 to 4 shot series. The last one is, I think it's 3 shots. The last one is optional. You don't necessarily need it. I think it depends on if your titer is high enough with the first 2, but it's highly recommended that you guys get that. Damn, my phone is blowing up. All right. So here's your different, yep. All right. A, B, C, and D. Those are your hepatitis variants. So fecal oral infected food or drink is what gets you hepatitis A. And then it just kind of goes in there into the other issues. You really don't have to know this table. Just know that there's 4 variants of hep. All right, meningitis. Why am I not full screen? Okay. Meningitis is an inflammation of the meninges, which is in the brain. Some symptoms include fever, headache, stiff neck, altered mental status. The biggest thing I want you to think about this mechanically. You have so much pressure in your skull, right? We maintain a certain pressure, and we call that ICP or intracranial pressure. Having intracranial pressure is not a problem. When people talk about head injuries and you hear ICP, ICP is not the problem. It's increased ICP that's the problem. Your body's going to maintain a certain pressure that is supposed to be there. But when things start to inflame, or if you have blood loss into the brain cavity or any of that kind of stuff, you start to increase that pressure. And now you have a hole at the base of your skull that the brain stem and attaches to the spinal cord, and it runs through that hole to get out of your skull and go down your spine. If you build up enough pressure in your head, where's it going to go? It's going to go the path of least resistance. There's only that one little exit. So the worse it gets, the more your brain and your brainstem start to get pushed down into that hole. And if it gets so bad that they push through it, that's called a brain herniation, and you're probably going to die from that one. Once a patient herniates, I don't know if it's 100%, but it's pretty high that they're not going to walk away from that. And that's also why you get that stiff neck. The more that swelling in the head starts to happen, the more it's going to hurt, the more your muscles are going to tense around the neck, and you're not going to want to be able to turn your head. So that stiff neck, that's a big sign. If you start to see people complaining about, headache, fever, altered mental status, if you're wondering if they got the flu, or if it looks like they're having a diabetic emergency, but their sugar is fine and you really can't find any other explanation, if they're alert to tell you or to talk to you, ask them if they have a stiff neck. That is one pointed question you can ask, because that's just a yes or no answer. Ask them, does it hurt to turn your head? Because if it does, then you're looking at meningitis. Now, there's a couple of ways you can get it. There's a viral and a bacterial. I'm not going to get too much into the weeds on that because I really just want you to know what meningitis is in itself. So take standard precautions. These can be contagious. Meningitis can be treated at the ED with antibiotics if it's bacterial, and if it's viral, it won't. But after treating a meningitis patient, contact your employer or health representative, because this is some bad juju. Even if you don't think you got it, it's good to go ahead and get checked. TB is we've pretty much beaten tuberculosis, but it is definitely out there. This is a respiratory infection that is completely airborne. Just being in the same room with somebody could put you at risk at getting TB. Typically, when you enter the medical field, you get tested for TB. That's where they put that little injection in your skin, in your forearm. And then, okay, good. Isn't Hep D from True Blood? Isn't that? No, that was something else. I think I know what you're talking about, something that was just in the show. I think I never actually watched all of that. Where was I? I got distracted. Anyway, all right. So TB is completely airborne, and yes, you're at a high risk of getting it. So, you're not going to wear. It's not like COVID. You're not going to wear a surgical mask to a TB patient. That's like bringing a knife to a gunfight. So it doesn't really work out in your favor to do so. N95 or HEPA masks are required to stop the spread of it, because the TB mist is so fine it will pass right through cloth. It's not going to do anything. And a lot of times, if like for hospitals, for example, they'll put patients into negative pressure rooms where the pressure in the room is less than the rest of the hospital, so that the pressure in the hospital, every time you open the door to go into that room, the pressure from outside the room pushes in with you, which stops the TB from coming out, because it's, everything goes to path of least resistance. So air's going to go into the room, not out of it. And then that keeps people from walking by these rooms from getting TB because there's a patient in there. Infectious agents can take hold in some patients much more easily because of reduced defenses. So when you go back to other issues like HIV, elderly patients, any immunocompromised patient, a lupus or whatever, they're at more of a risk for TB issues. Absolute protection from infection with the tubercle bacillus, the TB agent, does not exist. Even with an N95 filter, you can still get it. Because think about it, that's not a seal, right? Those N95 masks, they just sit on your face. So even if you get fitted for one, there's still some air gaps. I'm not trying to scare y'all, but it's the truth. So even with the mask, just be careful. The vaccine is rarely used in the United States. We really don't bother with the vaccine. We just test you to see if you've got it. So if you take that skin test and it comes back as positive, the next step is to go get a chest x-ray, because all that skin test does is check to see if you've been exposed to it. Doesn't mean you got it. If it comes back positive, it will always come back positive. Once you've shown that you've been exposed, it's always going to be the case. So whenever you take the test, if that's what happens, they send you for a chest X-ray, because you can actually see TB in a chest X-ray. It's kind of neat. So as long as you're in the field every couple of years, it probably wouldn't hurt for you to get your TB test done again, just to see. Whooping cough, also called pertussis. Whooping cough is an airborne disease caused by bacteria that mostly affects children. A lot of times it's, I guess, because they don't cover their mouth or whatever, and kids are in close proximity with each other when they're playing. The reason that it's called whooping cough is because it sounds like they're being whipped at the same time that they're coughing. When they cough, it's got a percussive, it's almost like they got it slapped in the back at the same time. The best way to prevent exposure is to be vaccinated, and you can also put a mask on the patient and yourself. So that being said, like, what's the, did it say it? I want to go over it if they said it. Okay. Anybody in here know what vaccine prevents the whooping cough or prevents you from getting whooping cough?
DTaP.
Tdap. Yep. Good. That's so I can see it. All right. Moving on. MRSA. This right here is scary to me. Anything that's resistant to an antibiotic, automatically a pretty big pucker factor, I guess you could say. And my mom fought with MRSA toward the end of her life. So, anybody's ever heard of staph infections? MRSA is basically just a staph infection that is resistant to the antibiotics that they give it. Is meningitis in the same category as TB? What do you mean? And how it's spread? So it is an infectious disease, yes, especially if it's bacterial. You can get it from your patient, but it's not airborne, to my knowledge. Meningitis is weird. There's a viral version and a bacterial version. One's worse than the other, but both can kill you if it's not treated. All right. Somebody's mic saying. There we go. All right, so talking about MRSA, like I said, that's just a staph infection that is resistant to some of the antibiotics that we usually give. Hopefully, it's not resistant to all of them. Some cases of MRSA are. So in the healthcare settings, MRSA is transmitted from patient to patient by the unwashed hands of healthcare providers. Imagine that. Studies have shown that 5 to 15% of healthcare providers carry MRSA in their nares, which is your nose, and it can be transferred to skin and other areas of the body through a break in the skin. Factors that increase the risk for developing MRSA include antibiotic therapy. Think about it. So, oh no, you're fine. Antibiotics, we're basically using a pesticide to fight something that's alive, a bacterial infection. If we don't use our antibiotics correctly, or we just use the same antibiotic for too long, eventually the infection that we're fighting is going to gain a resistance to that antibiotic. We're kind of fighting an uphill battle that we eventually are going to start to lose because there's only so many antibiotics out there. And that's kind of the problem with MRSA. There's like 3 or 4 antibiotics that we can give for a staph infection. And if they resist those 2, I think it's after the second resistance, it's classified as MRSA. And if the third or however many it is doesn't do it, then that's it. You're just shit out of luck. Like there's not going to be any more treatments. There's no more antibiotics that we have currently for that. So that's just something to keep in mind. This is kind of a horror chapter. But anyway, antibiotic therapy, the more antibiotics you take, the more likely you are to start to develop, or the bacteria that you've got is more likely to start to develop a resistance to it. Prolonged hospital stays, a stay in an intensive care or burn unit, and an exposure to an infected patient. Patients that are bedridden can have this as well. A lot of times you won't see that in EMS, but if you guys that were, I know we have a couple of CNAs in here. A lot of the times when you would go in there to rotate your patient, oh damn, that sucks. We had a problem with staph infections in basic, but not MRSA. Just because, we had to shave so much, and then we go to put our gas mask on that God knows how many other people wore before we got our hands on it. And we'd have these little micro cuts from shaving all the time. We don't think about it. TB, MRSA. That's why I asked. You got all 3, or you're just okay? I was about to say I mean, it's not good, but yeah, if you're walking around after having all three of those, dude, I want your autograph, but you can use somebody else's pen. Um, yeah, no, that does happen. You see it in colleges a lot too. Um, there was meningitis outbreaks at college when I was in the dorms. That's why it's a good thing to wear flip-flops to the shower, that kind of thing. You don't want to be barefoot in a public shower. So anyway, MRSA results in soft tissue infections because it is basically a staph infection. All right, some global health issues that we're going to talk about real quick. We are almost done, so I know it's not. I know it's 8 o'clock, and we would be taking a break, but I'm just going to press through because we're at the end of the lecture. So MERS-CoV, that's a Middle Eastern Respiratory Syndrome coronavirus. This is a virus found in animals in the Middle East. First human case of this was discovered in 2012. Most human infections are found in the Middle East, hence the name, but because we are a globally traveling species, we have a high risk of getting this anywhere. Cases of this have been found in Europe and the United States. It just hasn't turned into pandemic proportions. Some of the symptoms you're going to see: high fever, cough, muscle aches, vomiting, diarrhea. That's a lot of that is pretty much your typical coronavirus symptoms. It's like a cold, but um, it's just a different strain. So in some cases, you're going to get renal failure, which is your kidneys failing, respiratory failure, and death. And there's no cure or vaccines for this virus at present, which is kind of scary because this has been around for 8 years and we don't have a vaccine or a cure. How long do you think it's going to be before we get one for the current coronavirus? If you expect somebody has that MERS-CoV, place a surgical mask on the patient and notify the receiving facility. You can treat it like a hazmat scene. So let them know, yeah, very soon. Let them know that this is coming, all right, because this is something that can spread pretty easily. Same thing with this little horror show, Ebola. Ebola is scary because it will melt your insides, basically. Like if you got it, keep your fingers crossed. But I want to add this little bit of hope in there as well. Ebola is a little bit like HIV. Um, it's bad, but it's not easy to get. All right, it's not like you're gonna walk in the room with somebody and suddenly get Ebola. In 2014 is when this really took off in West Africa. This is another one of the previous president's challenges that he had to deal with. So an outbreak of Ebola virus took hold. We did get a couple of cases here in the States. It definitely hit some other countries and it caused international concern and it caused mass hysteria in some towns. I'm not going to name the town, but there's a town that one of the very highly respected members of the town was a high ranking member of a church and he did a humanitarian relief effort to West Africa. Um, he did not get Ebola, but when the town found out that he was coming back from a West African country, he may as well have. And they threatened him. They threatened his family. These were church people. They threatened his family. It was not pretty. It was straight up like if anybody's ever watched that TV show, The Mist, or TV movie, The Mist from Stephen King, how the town goes crazy when the mist rolls in with the monsters and everything, but the townspeople are just as dangerous to each other as the monsters are. That was pretty much what was happening in this town. So this was pretty bad. Um, Incubation period for Ebola, because it does still exist, is 6 to 12 days after exposure. Some symptoms may not appear for as long as 3 weeks. Symptoms include watery diarrhea, vomiting, fever, body aches, bleeding. This is kind of like a mix between the flu and food poisoning. Fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. So if you do wind up with somebody that somehow has Ebola, um, you can do scary movies. I love scary movies. Um, if you wind up with a patient you think has Ebola for whatever reason, they need to go to the ER and the ICU as quickly as possible. But again, maintain their dignity, but treat the call like a hazmat. Don't treat your patient like a hazmat, but treat your call like one. Notify the facility. They need to be able to gown up, get ready to get the patient where they need to go without infecting everybody in the hospital. And because we don't have any active cases in the States right now, this is something that you're going to want to notify the CDC about because they track every patient that has Ebola. All right, travel medicine. You must be aware of travel-acquired infections when assessing a patient who was recently outside the United States. It's one of those common questions that we ask everybody now. Patients can present with a variety of symptoms, including fever, cough, vomiting, bloody diarrhea, that's a bad day, body aches, and rashes. Patient may experience mild symptoms. Some of them may become extremely ill. Some are asymptomatic. It's just, there's so many conditions that play into it. When you encounter an ill patient with a recent travel history, place a mask on the patient. You can place a mask on yourself if you want to just double the protection. It's absolutely nothing wrong with that. And gather as much information as possible, not just your normal questions like sample and OPQRST, but really get those questions about who have you been in contact with? Have you been outside the country? Do you know anybody that's been outside the country? Try to build that track record, because when you start dealing with these bad juju only typically in other countries kind of illnesses that nobody has here, none of us really have the antibodies in our system to fight off Ebola or any of these issues that we've been talking about. So if something like that gets loose in this country, it's going to spread like wildfire because nobody's built up an immunity to it. When you encounter an ill patient we already said that. Okay, moving on. Some important questions. These are pretty commonly heard now because of COVID, but you have, where did you recently travel? Did you receive any vaccines? They've given me vaccines in the military. I don't even know what they are. It's like, hey, we're going to stick you with this. And it's worked pretty well because I haven't caught crap with everything going on. Kind of feel left out. Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What type of foods did you eat? Because some things are foodborne. In fact, I haven't read the article on it, but I think there's something with Walmart food that got recalled recently. If any of y'all know what I'm talking about, pop it into the chat. Let's see what types, but I know there was the peanut butter. Oh, some fruit. Okay, yeah. So there's that going on. I know that peanut butter got a bad rap for a while. Some kind of lettuce, romaine lettuce or spinach or something, got recalled a couple years back. A lot of times that question right there you go, romaine. That question right there is what determined it. Everybody with a certain illness is like, yeah, I was eating salads. Then they start to track it down. And then what was your source of drinking water? Did you drink tap water in Mexico, or did you stick to the bottled water? That kind of thing. If you suspect the patient has a communicable illness, follow your appropriate PPE and notify the receiving facility so they can do the same. And that's going to be pretty much it. The conclusion is, I know we kind of went over the greatest hits of the worst possible things you could get in the medical field. I don't want you guys to be afraid to leave your front door to go to work or anything like that. Just know that stuff is out there. Some of it's kind of like winning the lottery. Yeah, there's a chance, but it's not a good one, you know. Um, so don't be afraid to deal with your patients. And if you do come across patients with these, that's why we wear gloves. That's why we have the gown, the N95 mask, and stuff like that. So just trust in your equipment. Anybody that's been to basic training and gone through the gas chamber knows that they can trust in their equipment until they take it off, and then it's all downhill from there. Um, so, treat this the same. Yes, there's some bad stuff out there, but that's why we're here. Any questions on tonight? And while y'all are typing the no questions answers, I will be getting your pen ready. Okay. I don't know. That's a good question. So, do I think COVID is airborne? It's interesting how they've gone back and forth on that. Actually, let me give you your pin, and then I'll talk about it that way. I'm not holding everybody hostage. Your pin for the night is going to be B as in Bravo, C as in Charlie, the number 14, so 1-4, and then the letter M as in medical. BC14M. And there it is in the chat. So I don't know. When COVID first came around, and we weren't really sure at all how it spread. We had no idea. They said airborne, and we took airborne precautions. That's why everybody got fitted for N95 masks, stuff like that. Me personally, I don't think it's airborne. Not like TB is airborne. I don't think it's aerosolized. Mainly because if it was, I think it would have spread even worse than it has. If you notice, in areas like New York, where people have for the most part embraced and dealt with the masks, and you don't have a lot of people bucking the system on that, our infection rates have gone down. If it was airborne, those masks wouldn't really be doing anything. So I don't think it is, but that's just my opinion. I don't know. I haven't been locked in a room with somebody with COVID to really test that. What do you think? At the VA now in New Orleans, they have goggles as a precaution. Okay. So if you think about that, your goggles aren't from China. Your goggles, I'm going to stop the recording now. Your goggles don't protect you from airborne. They protect you from droplets just like the mask does.